Hi, my name is Yoda, and I'm the pharmacy intern covering the general medicine floor, returning a page about Mrs. Smith's current heparin continuous infusion. The patient is a 73-year-old female that weighs 63.6 kgs with a current serum creatinine of 0.9 mg per deciliter. The patient's current INR is 1, and the APTT is 80 seconds. The team is looking to switch her heparin 1,000 units per hour drip to enoxaparin. Unfractionated heparin and enoxaparin, or low molecular weight heparin, both work in the propagation phase to deactivate activated factors, but they have different mechanisms of action. So while heparin works on the intrinsic pathway, which consists of factors 12, 11, 10, 9, and 2A, and the common pathway, enoxaparin only inhibits factor 10A. I calculated the patient's current creatinine clearance to be 52.1 milliliters per minute, so a renal dose adjustment is not necessary at this time. For the treatment of a VTE, the usual dose of enoxaparin is 1 mg per kg twice daily or 1.5 mg per kg daily. In this case, I'd recommend enoxaparin 60 mg per 0.6 ml sub-Q injection twice daily. In the event that the patient's creatinine clearance goes below 30 mLs per minute, however, you can change the dose from 1 mg per kg twice daily to 1 mg per kg daily. To address the second part of your question, the enoxaparin can be initiated at any time, and the unfractionated heparin can be discontinued thereafter. So in terms of monitoring, an APTT is not useful for enoxaparin. An anti-10A level might be helpful in the event of obesity and renal insufficiency, but it is not necessary at this time. It is important to continue to monitor the patient's renal function because enoxaparin is a renally dosed medication. Anticoagulation therapy for the treatment of a VTE is indicated for at least 3 months. I found a randomized controlled partially blinded equivalence trial that demonstrated that enoxaparin twice daily or once daily was as effective and safe as a continuous infusion heparin in preventing a VTE. Enoxaparin is advantageous though because it's a medication that can be administered inpatient and outpatient. And as Mrs. Smith gets ready for discharge, you can decide whether you'd like to keep her on the same enoxaparin regimen or convert to an oral agent. Options for an oral direct thrombin inhibitor include rivaroxaban, edoxaban, and apixaban. If you end up choosing warfarin as the outpatient anticoagulant, it will be necessary to bridge the patient with enoxaparin for a few days to make sure they're adequately anticoagulated until the warfarin can have an effect. You can start the warfarin and discontinue the enoxaparin after 4 to 5 days and once the INR is greater than 2. So to summarize, the patient's heparin 1,000 units per hour drip can be converted to enoxaparin 60 mg per 0.6 ml subcutaneous injection twice daily. You can initiate the enoxaparin at any time, but once you start it, you can discontinue the heparin continuous infusion immediately. Enoxaparin can be used both inpatient and outpatient for a VTE. If you have any questions, please feel free to page me at beeper1234 or extension 5678. Thank you.